Hi, everyone, and welcome back to Critical Care Echocardiography. My name is Harrison Steins. I'm a current fourth year medical student and excited to be in the series with you. Today, we'll be looking at apical views, so apical 4, 5, and 2 chamber views, as well as MAPSE, otherwise known as mitral annular plane systolic excursion. So, overall, the apical 4 chamber is ideal for comparing right and left heart chambers, assessing global and segmental left ventricular function, and visualizing mitral and tricuspid valves. MAPSE, which is a subset and a view taken in the apical 4 chamber, provides a simple reproducible marker of left ventricular function longitudinally. And this is especially helpful in low resource settings where access to advanced echo strain imaging isn't possible. So MAPSE, mitral annular plane systolic excursion, also facilitates monitoring of cardiac function over time in septic or cardiogenic shock. So our clinical relevance for this topic today is that a symmetrical comparison of both ventricles and assessment of mitral and tricuspid valves, RV and LV ratio, can be important in a resource-limited setting when you don't have advanced echo tools or advanced continuous cardiac imaging or monitoring. So for our application, we're going to try and detect global systolic dysfunction, tricuspid regurg, and we can use some of these tools to estimate pulmonary pressures. And as far as utility of the apical views in MAPSE, MAPSE offers a simple and fast proxy for LV function when strain or ejection fraction estimates are impossible. And you can do it with most tools where you just have an M mode and then the ability to take calipers. So if you don't have more advanced echo tools or ultrasounds like cart-based systems that will calculate things for you, we're going to work through how you're going to be calculating this on your own. So moving on to our apical views, the 4-chamber view is the most widely used screening tool to detect structural cardiac abnormalities during routine fetal ultrasonography. So looking on adults, we're getting a lot of our images from maybe our peristernal long view, our apical 5-chamber view, but in looking for fetal abnormalities, we'll be using the apical 5-chamber view. Not saying we, but someone would be using apical 4-chamber view. So in a perfectly aligned 4-chamber view, the ventricle or the ventricular and atrial septum should be straight down, like you see right here. That means that the 4-chamber view should be vertical. However, clockwise rotation is often seen in people who are just starting to get these apical 4-chamber views. So this is the view that we're going for. You can see cardiac abnormalities here. If you were looking for, say, a VSD, ASD, you could put on color Doppler and try and see if there's flow between the ventricles or the atria. That shouldn't be there. At the apical 4-chamber view, we can go to the left ventricle. We're going to visually assess for myocardial thickness, wall motion, and then ejection fraction. We move up to the mitral valve. We're going to be assessing for mobility, structure, diameter, coaptation of those valves, similar to how we were assessing in the left ventricular or peristernal long axis view. We can place color Doppler over the mitral valve and start to see if we're getting the mixing of the colors, the mixing of the red or blue, which, remember, are flow moving toward or away from the transducer, not venous or arterial, as we often teach kind of new learners to ultrasound. So again, in the case of mitral regurg, continuous wave Doppler can be placed at the vena contracta. Again, you can see here that the ventricular and atrial septums are straight down, which is how we want to set up our exam. So in evaluating diastolic dysfunction, we're going to talk a little bit about the E to A ratio, but this is using spectral Doppler to reveal a biphasic flow. So the first wave, or first phase, denoted with the letter E, represents the passive emptying of the atrium, and the second phase, A, represents atrial contraction. And so we can take a look at the ratio between the emptying of the atrium and atrial contraction to evaluate ventricular relaxation, otherwise known as compliance. The less compliant the left ventricle is, then the larger A becomes, such that the E to A ratio is increased in some situations. This is somewhat out of the scope of this lecture, but I think that it's important to know that there are additional measurements for each of these valves, for each of the flow rates, so that we can evaluate diastolic, systolic dysfunction, or global heart function. So now we're going to be looking at MAPSE and TAPSE. MAPSE is the mitral and TAPSE is the tricuspid annular plane systolic excursion. So these are measurements that add valuable information to the function of the right and the left heart, and they highlight abnormalities that you might not see when you're just evaluating ejection fraction, and the ejection fraction is normal. So MAPSE uses M mode to assess the left ventricular systolic longitudinal function, so moving in a z-axis. It's a quick way to evaluate the left ventricle from an apical cardiac window, and it's useful because decreased excursion or movement of the mitral valve during systole correlates to left ventricular systolic dysfunction. This can actually precede changes in the left ventricular ejection fraction, so coming before you're seeing a change on like EPSS during an MI. So lower MAPSE can indicate systolic dysfunction overall. So how we're going to do this is to get a apical four-chamber view and then focus that on the mitral valve. Once we've focused it on the mitral valve in that apical four-chamber with the ventricular and atrial septums perpendicular to the ground in a horizontal or a parallel plane, we move the cursor over to the lateral aspect of the mitral annulus and then freeze image, and then we can measure the trough and peak. So the end of diastole and the end of systole, where that mitral annulus actually is. And taking that measurement, we can evaluate whether it's low of normal or at normal. Normal in the cardiology literature has been shown to be like 12 to 15 millimeters of excursion, so the difference in the systolic and diastolic location. And it's important to know that these values can be affected by local wall motion abnormalities that can affect the myocardium near the mitral valve, mitral annular calcification, or mitral valve prosthesis. So in the same way that in the parasternal long axis view, we had to know about mitral pathologic processes going on so that we could not generalize mitral function to global cardiac function or to left ventricular function. We have to know that here as well. Here's a video that shows everyone how to do it from the Echo Lady. It's an awesome video. It goes through all of the Echo steps, and I think everyone should check it out after this. So moving on to our tricuspid valve in the apical four-chamber view, we're assessing again for mobility, structure, how well the valve is coming together, palpitation, and we can put color Doppler over it to see presence of regurgitation or stenosis, and then we can measure the tricuspid annulus. Here you can see severe aortic regurg with color Doppler, so you're getting that mixing of color as you're going into systole there. Moving to the right ventricle, we're assessing for myocardial motion and thickening. We'll be looking at right ventricular size and strain. So what we don't want to be seeing is right ventricle greater than that 1/3 to 2/3 ratio that we saw of right ventricle to left ventricle, which could indicate some sort of hypertension, like pulmonary hypertension, a PE, pulmonary stenosis, things like that. Down in the bottom right, you can see typical measurements for right ventricular size. In the top right, this is where you would take those measurements. You take one parallel and then two perpendicular to the right ventricle. So I thought this was just interesting. This was a case that one of my colleagues had seen early on in medical school, the Epstein anomaly. So congenital heart defect, looking at right ventricular size. So the valve, tricuspid valve, is not forming as it should, and it's located lower than it is in a usual heart. Can occur between there's a hole, or when there's a hole between the two upper chambers of the heart, like ASD, classically taught, caused by lithium in pregnancy. But this is something where a measurement of the right ventricle would show that it's much smaller, and then a measurement of the right atrium would show that it's obviously much larger. So just an interesting clinical application of the case. So rounding out our apical four-chamber view, we're looking at the atrioventricular plane mobility. So this is just the movement of essentially the entire heart. So the whole AV plane should travel toward the apex, which we can see up here. during systole, and during diastole, the left ventricle relaxes, the AV plane recoils back towards starting position. So you can see the entire left ventricle starts to relax and move superiorly. For the left ventricular outflow tract, we can examine for regurg with color Doppler, and velocities are quantified with spectral Doppler. I didn't include the velocity measurements here because that's a bit outside the scope. For apical 5-chamber view, we can use, so apical 5-chamber, right, has both ventricles, the atria, and then it also has the aorta, so we can see kind of that Mercedes-Benz, the 3 cusps of that aortic valve right there. We can use color Doppler in the left ventricular outflow tract, aortic valve, and proximal aorta. All of those leaflets should be co-opting so that there shouldn't be color during either systole or diastole, whichever one is relevant to that valve. So direct the Doppler toward the aortic annulus and then place your sample proximal, 1 centimeter proximal to the annulus. You can use the continuous wave Doppler for aortic stenosis or regurg, and remember the actual evaluations of something like aortic stenosis are out of the scope of this lecture. Finally, we move on to the apical 2-chamber view. So in moving the transducer, you're starting from the apical 4-chamber view, then rotating 30 degrees counterclockwise, as shown in that kind of first figure there. The left ventricle and left atrium, as well as the mitral valve, get to be visualized. And then you can also see the left ventricle and the anterior wall and the inferior wall as well. So we can assess for leaflet cooptation again, presence of mitral regurg, which at this point we've probably assessed 3 or 4 times. And then you can use continuous wave Doppler to measure